So let's discuss this. I want to invite Dr. Professor Rahamim Ben Yosef, Professor Krausz, Professor Tuttle, and Professor Tzila Zwas to the podium. Please. And if you thought we're confused, I think let me introduce and start by asking this question. I'm not going to talk about tumors which are less than 1 centimeter. I'm going to talk about tumors which are between 1 to 4 centimeters. Okay, so does it make your decision, Professor Krausz, more difficult? If you have a tumor, you know it's papillary carcinoma, and it's a low-risk patient with all the criteria for that, and the tumor is between 1 to 4. What will you do for surgery? You have over there.
It's a difficult question because recent studies go up from 1 centimeter to 3 or 4 centimeters in low-risk patients. So in this type of patient that you suggested, I would first of all see is it a male, what age, and also very important, what is the opinion of the patient himself. Once the patient knows that he has a tumor of 2 or 3 centimeters, and he knows about this controversy, he will help me a lot in the decision. I am nowadays still in tumors larger than 1 centimeters, I would go for a total thyroidectomy, even though I read and listen to the current literature, and we are gradually changing a little bit about it. It's a difficult question, and I don't have an answer for you about it.
Thank you very much, Professor Krausz. Professor Tuttle, it's in the mid, it's 2.5, between 1 to 4, right? Low-risk patient. You can easily do total thyroidectomy. You will be happier, maybe, and the endocrinologist in the community will be more calm and happy. Maybe the patient will be more happy, easy to follow. You won't have to file papers if she will have distance metastasis in 40 years. Why shouldn't we do total thyroidectomy for a young patient with 2 centimeters papillary carcinoma?
This is great. So the 3 reasons he gave to do a total thyroidectomy had 0 to do with the patient. We're treating ourselves. We want to be more comfortable. We want to sleep better at night. We want to be more comfortable telling the patient. So in Israel, if it's important for the doctors to sleep at night, yes, do a total thyroidectomy. Or learn to sleep at night after a lobectomy. We can teach you how to do this. So I know it's good. I feel you guys are moving in the right direction. So what I tell these folks is even though we put 1 to 4 centimeters, you will find very few 4-centimeter papillary thyroid cancers with no lymph node metastasis, right? Because there's a link between size and lymph node metastasis. So this is really an argument with lobectomy, usually around 2 centimeters. So we are totally comfortable following with lobectomy, provided we have a good pre-op ultrasound, and I can trust my ultrasonographer, and we tell the patients all the time to let the surgeon make the final decision in the operating room. So the plan would be to do a lobectomy, although they're all consented for total, they're consented for central neck, but our plan would be to just do a lobectomy as long as the pre-op ultrasound was fine and the surgeon didn't find anything worrisome inside. Now, if I do that, that means I leave microscopic disease behind in the contralateral lobe a third of the time. I understand that. And it's papillary microcarcinoma. I'm comfortable with that. So part of the decision of doing that is they do have to get follow-up ultrasounds. not every year, like Dr. Hirsch's study. She said exactly right. These low-risk patients, you can ultrasound them every 5 years. I've got a sign on my desk that says it's okay to be wrong. In these low-risk patients, I'm going to be wrong 5 or 10% of the time, and they're going to need a completion thyroidectomy at some point in the future. So I think the goal is learning how to follow these guys, understand they really are low risk. The few that change, you're not going to pick up on an ultrasound in 1 year. You're going to find far more false positives in 1 year. But if you let things change, maybe an ultrasound in 3 or 5 years. And the patients are generally very comfortable with that.
And what do you gain from leaving one lobe?
So I don't believe for a second you can do a total thyroidectomy with the same complication rate as a lobectomy. That just defies logic. You're operating on 2 different sides of the neck. I know inexperienced hands. Give me a break. Ashok Shah did one for me, and I think he's one of the best on the planet, and we damaged a nerve last week. So I don't buy into it's just as safe to do both. I also think in the people that we do a lobectomy, we don't do a lobectomy if there's 1 million nodules on the other side. We don't do a lobectomy if there's Hashimoto's on the other side because that's going to be too hard to follow. So in the patients we choose for a lobectomy, they largely have a normal contralateral lobe, and they can maintain a TSH of 1 or 2 on that lobe on their own. So they don't have to go on thyroid hormone pills, and they feel better. I just don't think that doing a total thyroidectomy, if you're not going to be changing their overall survival, just because it can be done safely or just because we can do it in good hands is the right cancer surgery. I'm a minimalist. We also want to make sure that we don't miss the boat. There are certain patients we don't want to be minimalist on, and identifying who those are, either with your initial surgery or as part of your follow-up, is going to be important.
Professor Ben Yosef, so this patient, 2 centimeter nodule, papillary carcinoma, you could have given her only hemithyroidectomy, but now she underwent total thyroidectomy. Why most of our patients with low-risk small thyroid cancer will go to radioactive iodine therapy and ablation? Why is that?
It will not be for the physicians to give the radioactive. As Professor Tuttle say, we can sleep at night very well with leaving the patient after total thyroidectomy without giving him or her the radioactive iodine. However, if we can eliminate those with 10% of local recurrence after the total thyroidectomy for such patients, and with so less side effects after radioactive iodine, we should consider it. In the NCCN guidelines, they wrote it very nicely to say that you may consider radioactive iodine for those patients. It should not be given mandatory for those patients. You may consider, and it's based on various parameters as other risk factors. But basically, there is no need to do that as a routine basis.
Dr. Zwas, I want to ask you a question now. When I arrived from Sloan Kettering to Israel, I had a patient which entered my clinic. She had a low-risk patient. She was a low-risk patient. She, following surgery, total surgery, every year she had a radioactive iodine scan with starvation, without thyrogen, and she had to delay her pregnancy, and she wanted to ask me whether she needs really routine radioactive iodine scan for follow-up, with or without thyrogen, through the rest of her life, or even within the first few years after surgery. So I want to hear your approach towards the follow-up of these low-risk patients with radioactive iodine and with or without thyrogen.
I would say that there has been a major change now in the attitude, and we are foregoing with the stratification of these patients. We would rather follow those who have evidence for medium high risk disease, we are not wasting our time anymore so much anyway on the low risk unless there is a reason for that by those who have indefinitive evidence of recurrence due to lobectomies, due to incompleted treatment after having gone under ablation, iodine ablation. They have antibodies, positive antibodies and so on, or increasing titer of those, and all kinds of evidences which are suspicious for shortage of evidence by ultrasonography, whether or not we have lymph nodes there or not, involvement of that, so that there are many reasons for following, incidental following, and directed by case stratifications of the low-risk patients. Otherwise, we would not do it. They are referred to us for that, for these reasons. Otherwise, and also, we switched long time ago already from the withdrawal of L-toxin, or Eutirox for that matter, to thyrogen stimulation, so that there is no more just follow-up, routine follow-up of the low-risk patients. There are only those, as I said, who have evidence or suspicion that we need to go forward and further treat them. And for making the decision of further treatments, we would firstly do initial evaluation, either to prepare the patient, calibrate whatever needs to be given to him, and being more wise with selecting the right patients for further iodine treatment. We are not going now for the very high dosage either. We are rather standardizing the dosage too, trying to follow the guidelines of 30, 100, and so on by the histology, by the initial histology to begin with, and then by the risk stratifications as the patients are undergoing these follow-ups. I highly recommend that the follow-ups in Israel will be much tighter as far as qualification of ultrasound is concerned. We are not that good in any ultrasound we are doing or is being done here, so that we are not always able to rely on the results of the ultrasonographers, and many times we need FNAs to back it up, and so. And the TG is still a good measure to know what's going on as well, by stimulated TG, I mean. And if you have a hemithyroidectomy, for that matter, it's rather difficult, we all know that. So that there are pros and cons for everything we do with a low-risk patient. However, the trend is to minimize unnecessary follow-ups for these patients. That's for sure.
Thank you. Mike, before you comment on that, I want to understand, because there's a variability in the way each one of us in this room follow low-risk patients. We have ultrasound that can be done every 3 or 6 months till the rest of their life. We have the scans that we just heard. We have stimulated thyroglobulin. How would you follow this low-risk lady that you done hemithyroidectomy for 2-centimeter papillary carcinoma versus the same lady who had gone through total thyroidectomy?
To be honest with you, not very different. And this is something you have to learn. Because if you do a lobectomy and you're going to constantly worry about that patient and do an ultrasound every 6 months, you're going to fall into this trap of tremendous false positives. You're going to do a lot of biopsies. It's going to be a terrible experience for the patient, and you're better off just doing a total thyroidectomy. So when we do a lobectomy, I have them come back and see me in 6 months. I measure a thyroglobulin and I feel their neck. At 1 year, I do what I call my I told you so ultrasound, so that I can say, I told you so, it didn't change for the last year, you're not going to die. And then the patient sees me once a year with a TSH and a thyroglobulin, and I do another ultrasound in 5 years. That's essentially exactly the same follow-up if I've done a total thyroidectomy or a lobectomy. Yeah, that's what I really do, and my patients aren't dying. It's okay. The key, translate that because you didn't misunderstand me. The key to that approach, and I really liked being here. You can't throw me out yet. I haven't given my talk. The key to that approach is the proper selection of patients for lobectomy. Remember, the patients that we choose to do lobectomy, they've got a normal contralateral lobe. And in our hands, the thyroid globulin is usually about 3 or 4. So after a lobectomy, we leave a normal lobe behind. The suppressed thyroid globulin is 3 or 4. A year later, the ultrasound's exactly the same. You're looking at a normal ultrasound. The thyroid globulin is still 3 or 4, and then you feel really comfortable. You can't do that if you're trying to do Hashimoto's thyroiditis with a lobectomy or multinodular goiter with a lobectomy. That just doesn't work. In Germany, they'll never do a lobectomy because they never see a normal contralateral lobe. So when you talk about how you do the follow-up, it has to be that. The last thing that I'll tell you is even when you did total thyroidectomy and radioactive iodine, we have a paper coming out in JCNM that says if you do yearly ultrasounds on those patients, your false positive rate at Memorial in our hands is 40%. The recurrence rate was 1%. So that's even with total thyroidectomy and radioactive iodine. So we're now starting to take a real look at the issue Dr. Hirsch brought up, which is that intensity of follow-up. If you're going to be less aggressive up front, you have to be less intense in the follow-up, or you'll get all the false positives as well. So the ATA new guidelines are going to endorse not only less intense initial therapy, but also less intense follow-up once they achieve that excellent response. So that we're not overutilizing resources, we're getting the right therapy to the right patients, because in the minimalistic approach, you have to really believe they're low risk. If you don't believe they're low risk, the patient won't believe they're low risk, their husband won't believe they're low risk. You got to sell that when you walk into the room. If you walk into the room and say, lobectomy is fine, but I'm really going to worry about you, you'll never do a lobectomy. So part of it, you have to believe that that's an acceptable thing.
Any comment from the other panel members?
There's about 30 to 60% of patients with multifocality in the other lobe. And you just say, okay, we can follow them for once in a 5 year.
So I truly believe that. So there is no question when we do a lobectomy, we are more than likely leaving microscopic disease behind the contralateral lobe. I'm also perfectly happy with not even operating on this patient to begin with. So, yeah, but I wasn't going to tell you that because you would, I don't know, something bad would happen to me at the break. So do you think I worry about microscopic disease in the contralateral lobe that I can't see if I'm willing to follow with observation microscopic disease in the lobe that I can see? So this patient in my clinic would actually be given the option of watching versus going to lobectomy or total thyroidectomy. We now have about 250 patients that I've been following for 3 or 4 years. Our experience looks exactly the same as Ito and the Japanese, that in properly selected patients, they grow very, very slowly. They grow about 1 millimeter a year. So if you're watching at a 5-year interval and there's nothing there now, the biggest you're going to see is 5 or 6 millimeters in 5 years and still be very treatable and avoid the false positives. So there has to be this understanding that it's okay to leave disease in the contralateral lobe. That's why the Mayo Clinic shows fewer recurrence rates if you do a total. Because if you take all of that out up front, not much of it grows. So in our hands, about 10% of the time we have to go back and do a completion. But that means 90% of the folks are left with their thyroid forever, which is why, as you're saying, the patient has to be on board with that, and they have to be comfortable. When we follow these papillary microcarcinomas, we have a paper that's about to come out in thyroid that we wrote with Ito and Sugatani from Japan and said picking the right patients matters. It's tumor characteristics, because probably this 8 millimeter thing was up underneath the capsule that would have suggested extrathyroid extension, and we would have said don't watch. It's tumor characteristics. It's patient characteristics. Are they willing to follow with you? Are they going to do their follow-up? And the third, it's medical team characteristics. What's the quality of your ultrasound, surgery, and all that sort of stuff? So we're going to say there's 3 domains you have to think about, not just size, when we're making the decision for observation, but you can extend that same thought process out to making the decision for lobectomy versus total thyroidectomy, not just size, the whole piece.
Thank you. We discussed yesterday, in my clinic, the first 5 minutes, I'm sensing the patients. If it's a low risk or high risk, and what the patient wants me to do, hemi or total. Then the next 15 minutes, I'm discussing the treatment with the patients. Now, I want to approach the audience. Is there any questions that you would like to ask? Please.
When you say that you do a amylobectomy, that the contralateral lobe is normal, would this patient classify having an FMA benign, just one nodule benign?
So the question is, when I say we only do a lobectomy if the contralateral lobe is normal, would this patient count as a biopsy? In my hands, yes. In your hands, no. So when you start to do lobectomies, this is not the right person to start with. You don't want to try to follow a 2-centimeter nodule. In my hands, we would call this acceptable but not optimal. So optimal means the other side is completely normal. And when I go around the world, that's where I teach you to start. Start with optimal. If you're really in my clinic, because I have to tell the truth, because Dr. Robenstock was in my clinic for a year, he knows I follow people with nodules on the other side. They have to be a little more motivated. They have to kind of really not want a total thyroidectomy. And I'm comfortable doing that. But to start with, I say start with just the ones that have a normal contralateral lobe. The more nodules you get on the other side, the more suspicious. It just practically becomes harder to follow. You know I'm not going to be able to wait 5 years to do an ultrasound on that patient. I'm going to have to do a few more. So while it's not mandatory, it makes it much more difficult.
Yeah. Last question, please.
Thank you very much for this interesting session. I would like to ask you regarding agents between 1 and 2 centimeters, and we do lobectomy, and the pathology is called papillary thyroid carcinoma with total cell variant. Do you think that we should decide to make total thyroid easier to do this into papillary thyroid?
Yeah, so the question is, you've done a lobectomy, and surprisingly, after the lobectomy, it turns out to be a 2-centimeter tall cell variant of papillary carcinoma. It turns out this doesn't happen as often as you think, because most tall cell variants, by the time they get to 2 centimeters, either have some extrathyroid extension or some lymph nodes, so they generally get a total thyroidectomy. But we will occasionally be faced with this, either a tall cell like that, or sometimes vascular invasion, that it's a 2-centimeter papillary and there's extensive vascular invasion. With the vascular invasion, we almost always go back and do a completion thyroidectomy because we want the radioactive iodine. With the tall cell variants, it depends on which one of us that you see. Me, if it's totally confined to the thyroid and there's no extrathyroid extension, I'm okay with a lobectomy. Most of my partners would want to do total thyroidectomy and radioactive iodine because of the slightly higher risk. The reason people seek me out because they want a lobectomy. So when I tell you, right? So if you want a total thyroidectomy, you're probably not flying to New York to see me. So in that group of patients, even when I tell them it's a tall cell, they say, well, it's confined to the thyroid, right? There's no lymph nodes, right? I don't have to do something. So it's just by virtue of those patients, I don't always do a completion thyroidectomy. But I teach my fellows, you have to have a low threshold to go back and do that completion thyroidectomy. But you saw in our paper, in 10 years, we only did that like 70 times. So we're pretty good at guessing up front, but the patients have to understand, if we do a total, there's a small chance a week later we tell you, sorry, you have to go back and do a completion thyroidectomy, and they buy into that.
Okay, thank you very much.